Hello, my name is Amira Al-Gogari. I'm a third-year resident at Naples Comprehensive Health. This is my poster titled Challenging the Norms, a case of giant cell arteritis with polymyalgia rheumatica despite atypical inflammatory markers. Giant cell arteritis and polymyalgia rheumatica are autoimmune disorders that often coexist and primarily affect older adults. GCA involves inflammation of large and medium-sized arteries, presenting with symptoms such as headaches, scalp pain, jaw claudication, and visual disturbances. PMR is characterized by pain and stiffness in the proximal muscles, especially in the shoulders, hips, and neck. Diagnosis typically relies on elevated inflammatory markers, particularly ESR. However, some patients may have normal or low ESR, complicating the diagnosis and delaying treatment. Delayed treatment can lead to serious complications. Our patient is a 59-year-old female with a history of type 2 diabetes, hyperlipidemia, and hypothyroidism, presented to our ED with a 2-week history of acute onset bilateral shoulder and thigh pain and weakness. Symptoms were associated with sharp right temple pain, headaches, jaw pain, and night sweats. She was initially diagnosed with lumbar radiculopathy at another facility and received a 7-day course of prednisone 20 milligrams daily. As symptoms worsened, she presented to our ED. In the ED, she was hemodynamically stable with mild leukocytosis, mildly elevated ESR at 28, and an elevated CRP at 8.2. CMP, CPK, aldolase, TSH, procalcitonin, A1C, and lactate were normal. CT scans of the head, chest, abdomen, pelvis, and bilateral lower extremity duplex were unremarkable. Physical exam showed intact cranial nerves, decreased bilateral grip strength, and bilateral lower extremity weakness. Sensation was intact. Tenderness and diminished pulsation in the right temporal artery with an intact left temporal pulse were elicited. She was admitted for the evaluation of the new onset proximal myalgias and weakness, concerning for PMR and suspected temporal arteritis, and she was started on prednisone 60 milligrams daily. A temporal artery biopsy confirmed temporal arteritis as shown in figure 1. Her symptoms improved with treatment. She was discharged on a prednisone taper and scheduled to follow up with outpatient rheumatology. Traditionally, elevated ESR was a key in diagnosing GCA, but recent cases have been confirmed with normal or slightly elevated ESR, challenging this belief. Studies, including those by Mahgoub et al. And Chima et al., suggest that normal inflammatory markers should not rule out GCA or PMR. Spintana et al. Found that about 4% of GCA patients might present with normal ESR and CRP, often with more prominent PMR symptoms similar to our patients. Our patient had received a short course of corticosteroids, possibly lowering her ESR levels, a finding supported by Kermani et al. The evolution of the ACR classification criteria for GCA from the 1990 shown in Table 1 to the 2022 criteria shown in Table 2 reflects efforts to better capture the disease's variability, integrating a broader range of clinical features and advanced imaging. In our case, the biopsy confirmed GCA despite a mildly elevated ESR, underscoring the importance of clinical judgment and timely biopsy, ensuring early treatment to prevent severe complications like vision loss. Thank you.